Tim Siegler here again for the Brainwaves podcast. It's easy to be fooled in neurology. While we do have a number of available diagnostic instruments at our disposal, head CT, MRI, EMG, EEG, CSF testing, sometimes the patient's clinical syndrome won't jive with the results of your neurodiagnostic test. And this happens a lot. Last April Fool's Day 2017, we covered a few examples of neurologic conditions that can fool you on the basis of a normal quantitative test. When the EMG can be normal and the patient has peripheral nerve disease, for example. In these situations, it can be extremely difficult unless some alternative form of a diagnostic test is available. For instance, antibody testing in acquired autoimmune neuropathies. And this can leave the medical provider with the regrettable sense of disservice to the patient. And for the patient, it can leave them disgruntled, if not mistreated. While we are definitely gaining ground in our diagnostic modalities, lack of confirmatory testing remains a pervasive problem for many neurologic conditions. This is particularly true of functional movement disorders, as we discussed with Dr. LaFaver back in November of last year. This week on the Brainwaves podcast, we'll review how one non-traditional diagnostic test may inform us of the neurobiology that underlies functional movement disorders. Stay with us.
This episode was brought to you in part by Audible. With nearly 200,000 ad-free audiobooks, I'm sure you'll find something you'd like. I recommend Brain on Fire by Susanna Cahalan. It's the story of a Washington Post reporter who describes in vivid detail her battle with anti-NMDA receptor encephalitis. To hear this book and get your free 30-day trial, go to audibletrial.com/brainwaves and sign up. The first month is free and less than $15 a month for each subsequent month, with no cancellation fees. So take a minute to sign up for free at audibletrial.com/brainwaves.
I'm joined on today's program by Dr. Mark Hallett.
I am chief of the Human Motor Control Section at the National Institute of Neurological Disorders and Stroke, which is part of the National Institutes of Health.
Dr. Hallett has authored over 400 peer-reviewed publications in movement disorders over the course of his 30-plus year career working at the NIH, and before that, he had spent 10 years at the Brigham and Women's Center in Boston, Massachusetts. I asked Dr. Hallett to join me today because of his extensive experience researching functional movement disorders and the biology that may explain it. Specifically, what is it that the brain is doing when a patient suffers from a functional neurologic disorder? What does the brain look like? Structurally, the brain probably looks no different from yours or mine on head CT or MRI. But when you look at the brain activity, there is something unusual about the brain of a functional patient. But we're getting ahead of ourselves. Let's start simple and we'll move our way forward. Beginning with, how is it that we evaluate the function of an active brain? One way is to use functional magnetic resonance imaging, or fMRI.
Functional MRI has been designed to look at activity of different regions of brain. The size of the region varies depending upon the voxel size, but certainly there would be thousands of neurons involved even in the smallest region.
By voxel size, Dr. Hallett refers to volume element, or a three-dimensional pixel.
Now, the amount of activity that functional MRI measures is actually a measure of blood flow. The method that almost everyone uses is called the BOLD technique.
BOLD indicating blood oxygen level dependent imaging, with increases in BOLD signal correlating to higher regions of cerebral blood flow, with presumably higher metabolic demand of that particular brain tissue due to a greater activity.
So that you wind up with a signal relating to blood flow, which is an indirect measure of activity of that region.
And that's a big point that fMRI researchers make, is that these signals are an indirect measure of activity.
One would prefer to get direct measurement of activity.
We're assuming that the increases in regional cerebral blood flow on fMRI correspond with a functional change in these brain regions. So when Broca's area lights up when you're speaking on fMRI, we assume that that's because Broca's area is being used for speech production. In an ideal world, though, you would like for your diagnostic test to directly illustrate brain activity.
EEG, for example, is direct measurement of activity. And the problem with that is that the spatial resolution of it is not as good as functional MRI. So one has to compromise these different elements when one is trying to study the situation.
All right, so that's the basics of functional MRI and alternative measures of brain activity like EEG. What Dr. Hallett and his collaborators have done is they've leveraged fMRI technology to determine what, if any, anatomic structures are activated or suppressed in the aberrant neurological signaling in functional movement disorders. Makes sense, right? So, in their 2016 study that was published in Neurology, they selected a population of 35 patients with various functional movement disorders.
And these patients are very common.
They have functional tremor, jerking movements, imbalance,
presumably due to a psychological basis of some kind.
And Dr. Hallett compared these patients' resting fMRI data to the fMRI data of 35 healthy age and sex-matched control patients.
Now, what is characteristic of these patients is that when they have these abnormal movements, they are fully involuntary.
Now, this is an important point, because in some circles, it's still controversial as to whether patients with FMD have a true biological problem that explains their symptoms, or whether they are maybe faking it. Dr. Hallett and Dr. LaFaver, who was on the show before, and most other neurologists recognize these movements are involuntary, and we'll get to why that's important in a minute.
Now that gets into the issue of agency. The notion of agency is that one is the agent of the activity that just happened. And in the case of movement of the body, one is the agent of one's own body movements, and that would be called self-agency.
So self-agency, the awareness that one's controlling one's own actions.
I am the person that is responsible for my own movements.
Self-agency relies on a constant state of internal monitoring of whether one's actions occur as predicted. In the movement disorders world, some might call this the influential comparator model. Think about it this way. All movements start with some basic internal drive to move.
Have to have a sense of willing.
A sense of willing to raise your hand in the air, for example.
And then the movement has to happen.
Your hand goes up in the air.
And then the sensory systems of the brain indicate that something has happened that is appropriate to what you have willed.
You see that your hand is up in the air, you feel its position has changed from resting at your side to hanging over your head, and as long as your intention to raise your hand, the motor activity of your extremity, and the sensory perception of your hand having moved through space are all congruent,
that would indicate that you are the agent of the thing that just happened.
And by definition, impairment in self-agency is what defines a functional movement disorder. Patients with FMD lack that normal neural connection between a volitional movement and an appropriate sensory feedback. So what Dr. Hallett and his team did was to try to identify which areas of the brain have functional differences in patients with FMD versus healthy controls. And his team did this using a resting state fMRI.
Resting state functional MRI is done in a situation where someone just lies in the scanner and tries to think about nothing in particular. There isn't anything particular that one is doing, and one gets into a so-called resting state of the brain.
By looking at the metabolic activity as a surrogate marker for anatomic functioning of the resting state of the brain, we're able to get an idea as to what neural networks are active at a baseline state, which ones may be hyperactive, and which ones may be pathologically hypoactive.
And one can get a hint of what those networks are in the resting state of the brain, even though nothing is particularly happening. And one of the main things that we were interested in was the right temporoparietal junction. And the reason for that is, as I mentioned before, the patients do not have a sense of self-agency, and the right temporoparietal junction has been an area that is strongly related to the sense of agency.
Specifically, in that influential comparator model, the right temporoparietal junction plays the role of mismatch detector, and it's a critical component of this biofeedback pathway from motor event to sensory perception of the movement. In circumstances where the perceived action does not coincide with the intention, This is what patients feel or identify as an involuntary movement, or a sense of movement without agency.
The right temporoparietal junction is sitting in a very good spot for getting the feed forward and feed back signals, and probably is one of the principal nodes for the combination of that feed forward and feed back that will lead to the sense of self-agency.
The right temporoparietal junction is also a central node involved in maintaining attention, and when it's damaged, due to stroke for example, it can result in a state of hemi-neglect for that left side. You've probably seen this before. And with all this background in mind, Dr. Hallett and colleagues looked into the resting state of that right temporoparietal junction in patients who did and did not have FMD. But again, this was only the resting state of the brain, not the function of the brain during an involuntary movement. As it turns out, Hallett's team had already conducted a similar study of patients with a functional tremor. But instead of mapping out bold signal changes of the brain during its resting state, Dr. Hallett recorded brain activity while each patient was experiencing his or her functional tremor.
And in that study, those patients were able to mimic their involuntary tremor voluntarily.
Meaning those functional patients were asked to fake their functional symptoms.
When we looked at the patients, we or no one else could tell whether it was voluntary or involuntary. They had to tell us. So we put those patients in the scanner. They had their involuntary tremor. They had their voluntary tremor. It looked the same, but we wanted to see what was different in the MRI. And in that situation, one of the major differences was the right temporoparietal junction.
In that study, Dr. Hallett observed a reduction in the activity of the right temporoparietal junction during the involuntary functional movement, but not during the feigned functional movement when patients were faking it. So this finding raised a lot of questions, like, is there something wrong with the right temporoparietal junction when a patient is actively exhibiting the functional disorder? Or is the problem even more pervasive? Meaning, do patients with FMD have an underlying dysfunction of the right temporoparietal junction all the time?
What we did in the current study was to look at the connectivity of the right temporoparietal junction, not necessarily the level of activation per se. And that is an important difference also between the two studies. To go back to what I was saying before,
so in the current study, the 2016 case control study using resting fMRI, Dr. Hallett and his team sought to identify the underlying networks that were impaired, and not just to confirm that the activity of the right temporoparietal junction was reduced at rest. He wanted to see how this right TPJ, the mismatch detector, communicated with other brain regions responsible for the planning, execution, and the awareness of movement.
And what we found particularly was that the right temporoparietal junction is networked to multiple areas involved in the motor system.
Specifically, Dr. Hallett's team observed that the right temporoparietal junction communicates with
the motor cortex itself,
which, as you know, is responsible for executing the movement,
the cerebellum,
which provides continuous feedback to the primary motor cortex via the ventrolateral thalamic nucleus in order to coordinate the power and the timing of movements, and the
supplementary motor area,
which is involved in the planning of complex movements.
All these parts are critical junctions in the way that movement is produced and understood by the brain.
Other important connections to the right temporoparietal junction that are impaired at the resting state in patients with FMD were regions like the posterior cingulate cortex, which is a central component of the default mode network, a brain region that activates when the patient's awake, but his or her mind is wandering and even envisioning the future. Connections with the precuneus are also impaired, and the precuneus is a region of the superior parietal cortex that helps your brain transform visual information into a motor command. If you're not in your car right now listening to this podcast, let's just imagine you are, and say you want to veer to the left. The precuneus is involved in planning out how far you need to rotate your hands on the wheel to the left in order to turn your car appropriately without crashing into a street sign.
In ordinary circumstances, that region is strongly connected, and we identified the sort of lack of those or dampening of those connections in these patients.
Compared to healthy controls, patients with functional tremor or functional gait imbalance had less robust connections between the right temporoparietal junction and these other brain regions.
these are patients that have abnormalities of motor function and have abnormalities of agency. And the type of connectivity abnormalities that we saw make very good sense in terms of understanding the basic clinical phenomenology that we are seeing.
There are a lot of implications for this research, both from a psychiatric perspective and also from a neurological perspective. How do these data tell us about the pathophysiology that underlies FMD, and what does this mean for our care of patients moving forward?
So one of the aspects about functional movement disorders is there has been some confusion in the mind of neurologists about various aspects. One of them is that, quote, there is nothing wrong in the brain. And another one is that quote, the patients are lying to us. They are actually able to do all these things, but they aren't giving us the straight story. Now, I think that the fact that we can find some abnormality in brain function, and particularly related to the sense of voluntariness, gives us some insight that the patients do have a real malfunction of the brain that is underlying the clinical symptomatology that we see. This is something that they're not making up. It's something that they're not doing voluntarily. There's some dysfunction of the brain, which is why we call it a functional disorder.
One thing that I came across when reading your paper, which you all did address in the limitations section, was that you studied this cohort as inpatients. So each of these patients were presumably informed about their diagnosis of a functional movement disorder, and they either accepted it or didn't accept it, but they accepted it to the point that they wanted to participate in this clinical study. How does that perhaps skew the population that you studied, despite the fact that you did include a variety of different functional disorders?
Yes, well, I think that all research studies do have to face problems like that. I mean, one would like to be able to study all comers, but if they don't want to be studied or they don't accept the diagnosis, you're not going to be able to study them.
And I think that's a really challenging problem to correct for, especially in a patient population where psychiatric comorbidities are common and can certainly influence the way that people perceive their own condition and respond to treatment. Not to mention, their condition is largely identified as a diagnosis of exclusion.
We are doing this work in the context of very extensive evaluation of all the patients. We are getting many types of imaging. We are getting many types of psychological and psychiatric scales, genetic studies. We're doing all sorts of things in these patients, and they come in for several days. They do have to agree to do that. They do have to have some agreement that they have the particular disorder under our interest. And I think that it would be pretty hard to study people otherwise, I'm afraid. But it isn't, therefore, studying everybody.
That wraps it up for our program this week. Thanks for tuning in to more fantastic content on the neurobiology that underlies functional movement disorders, and for taking the incredible message that people still aren't getting that these patients are not faking their disease. There's truly something abnormal about that underlying neural circuitry. For more information on what we discussed and for some additional resources, check out the blog at brainwaves.me. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. Voiceover by Erica Mejia. I'd like to thank Dr. Mark Hallett of the National Institutes of Health, NINDS, for joining me on today's program. For full disclosures, please refer to this week's show notes. Music in our program was courtesy of Damiano Baldoni, Kevin MacLeod, Androsic, and the Philadelphia String Quartet. I'm Jim Siegler. Thanks for listening.